It's my pleasure to speak here. Some doctors believe that the future is FUE, that the FUT will be replaced. How true is it? Both techniques have been performed for more than 10 years. It's time to have a fair and balanced review of the two techniques regarding their indications and limitations. FUE has gained increased popularity because of the improved techniques and instrumentations. There are more doctors' involvement, especially the novice physician. And lastly is the marketing. The problem with FUE, transection is still the major problem. Transection occurs during the punch insertion and also the graft damage due to shearing during the extraction phase. With the improved technique and instrumentation, transection decreased substantially. However, in most hands, transection is still very high. FUE grafts are essentially stripped of any investing tissue. This may lead to desiccation, and the grafts handling are more difficult. This may also allow the follicles to splay, and the places they have to grasp the distal end for implantation. The risk of crushing injury increases. And lastly, the grafts may be kinked at the distal ends. This may lead to curved or kinky hair or the non-viable grafts. All these factors may be responsible for the occasional reports of suboptimal growths. The other potential problems are potential use of non-safe area. It is a slow and tedious technique, and the donor area might end up with white walling and hypopigmentation. The technique is difficult to master. It has a long learning curve. These are the scarring from FUT and FUE. The linear one is the FUT, and the rest are FUE scars. Both techniques definitely produce scars. There is no such thing as scarless procedure. This patient received prior FUE. The subsequent session made FUE impossible because of the extensive fibrosis generated. FUE harvesting in narrow area can produce linearity of scarring. Over-harvesting can produce a see-through effect of white walling and hypopigmentation. The indications of FUE are well known. Of these, the body hair transplant and the combination FUT and FUE for bigger single session. In fact, these two indications are on increasing demands. The problems with FUT, you may end up with a widened scar, and you need a big team for mega and giga sessions, and the physicians are out of control of every single step. The facts with FUT, the technique has been performed for more than 10 years. It's been proven to be effective and successful. It has a high patient satisfaction. The technique is relatively easy to master, and all suitable candidates for hair transplant can receive FUT. Shall we replace FUT to FUE because of the donor scar issue? FUT should be replaced when there is an unanimous consensus that FUE produces better results than FUT. However, this is very unlikely at this moment. The majority of patients, they come back for more hair, more density, not for the donor scar issue. This is my typical FUE patients. I try to limit a small area, and in mature patients, in home, future sessions are not anticipated. These are my average FUT patients in one session. Patients are happy, and the results are easily achieved in most hands. There are candidates who are only suitable for FUT, and some candidates who are only suitable for FUE. Some candidates can be done either one technique, and some for a combination of both techniques. The analogy would be if you are traveling from Asia to America, you have different options. You may go by air, you may go by sea. Each option serves different people with different needs. They coexist and will not be replaced. This patient wants only one session, as many grafts as possible. He has a lot of beard. We perform one session combination grafting consisted of FUT and FUE from the beard. The results are dramatic. There is a tendency that physicians mastering only one technique will claim superiority of the technique over any other and vice versa. In fact, there is an increasing trend that a patient might receive both techniques in the whole treatment course. It's imperative that the physician should master both techniques. Ability to perform just one technique and not the other results in failure to provide the best treatment option to our patients. At this point, FUT will remain as the mainstream surgery, and FUE will continue to rise. And both are winners. FUT and FUE will stay as they are now. No PK, no knockout. Thank you.